Welcome to another Puscast. It's January 1st, 2013. Happy New Year. This covers the last 2 weeks of December 2012 and will be the first podcast of 2013. There will be a lot of background noise during this podcast. I do this upstairs in my quote studio unquote, which is just a desk with a microphone and a pop filter. My eldest son is home. All his friends are over. They're watching bowl games and playing video games, and I'm not even going to bother to shush them. But if you hear lots of extraneous noise, you're going to have to live with it this time. Otherwise, let's move on to the literature. There is this curious literature on if your gut microbiome has a certain constituency, then you're more likely to be thin. And if it has another constituency, you're more likely to be obese. It's also been known for years that if you give farm animals antibiotics, that they get fatter and bigger more quickly. And would this be true in humans as well? Interesting to hypothesize. In this study, looked at early exposure to antibiotics and subsequent increased body mass index in children, and found an association between having been on antibiotics in the first 6 months of life and subsequently being larger than average. So if you were exposed to antibiotics in the first 6 months of life, you were more likely to be obese at age 38 months. But it faded by 7 years. If I was really smart, I would write the microbiome diet and make a fortune. A quick Google demonstrates that no one's done it yet. Maybe that's my road to fame and wealth. Ain't going to be this podcast. One of the consistent clinical brain farts I see is when someone has been on a course of antibiotics, let's say ceftriaxone for 10 days, and then the antibiotics are stopped and the patient has a fever or decompensates, and they get put back on the ceftriaxone. It's almost always the wrong thing to do, because by that stage of the game, they're likely to have infections that are resistant to, say, ceftriaxone. This study looked at this particular aspect of empiric therapy in neutropenic febrile patients and looked at the consequence of prior antibiotics on future susceptibilities. And guess what? Prior antibiotics markedly decrease susceptibility and, if you chose wrong, increase mortality. Most people, not unsurprisingly, use piperacillin tazobactam, which is the D-cerebrate antibiotic of choice these days. And patients on pip/tazo with their initial therapy had a subsequent decrease in susceptibility to 22%. So if your patient was neutropenic febrile with one episode and you treat them with pip/tazo, they come in with a second episode of neutropenic fever with another round of chemo. You don't put them back on the pip/tazo this time. You switch classes. This also happened with ceftazidime and meropenem, though not quite as dramatically as with pip/tazo. Take home. Look at the patient's prior antibiotic regimen and take it into consideration in choosing subsequent antibiotic regimens. A couple of years ago in CID, there was an article that demonstrated that antibiotic prophylaxis for dental procedures for prosthetic joints didn't work. This concept has now been embraced by the American Dental Association and the American Academy of Orthopedic Surgeons, who recently released guidelines about the prevention of orthopedic implant infections undergoing dental procedures, and said, "Dunna give the antibiotics. They don't work. There's no data to suggest they work. The data that is out there says it doesn't work, and the data that initially led to the recommendations was based on an entirely different disease, endocarditis." So now it will take, 25 years for that to filter through practice? I don't know, maybe longer. It's been like 160 years and people still don't wash their damn hands right. A recent study in, JAMA, I think? Or was it Lancet? Placebo-controlled trial using vitamin D to prevent infections in normal people did not have any efficacy. This study was done up in Sweden at the Karolinska Institute. I imagine if there's any place where there's buckets of vitamin D deficiency, it's going to be up north in the Scandinavian countries. And they randomized patients to getting 4,000 intravenous units of vitamin D3 or placebo daily for a year. But here is the clincher in this study. These are patients with immunologic deficiencies. They had antibody deficiencies of variable types, or they had more than 4 respiratory tract infections a year, but with no immunologic defect noted. Those who received vitamin D had fewer symptomatic infections and used less antibiotics, and at the end of therapy had higher vitamin D levels than those who were not on vitamin D. So in an immunologically deficient population, both proven and suspected, in an area without any sunlight, Sweden, vitamin D supplementation was beneficial in reducing symptomatic respiratory infections by about 25%. That may be applicable to Portland, Oregon, though maybe not to Baton Rouge, Louisiana. Infection control in the hospital has 2 purposes. One, of course, is to prevent the spread from patient to patient. The other is to protect the healthcare worker from getting whatever infection is going around. I have found over the years that emergency room personnel are a wee bit more cavalier about their personal protection against infectious diseases. And I've always wondered if that translates into, say, more days off due to illness in the emergency room. Probably unlikely since healthcare providers are likely to come to work sick, or if they're more likely to get various and sundry infectious diseases over the general population. At least when it comes to influenza, the answer might be no. This study looked at the seropositivity to H1N1 in frontline ER workers versus the general population and found that they had rates that were no higher than the general population. However, the caveat I would say is that during the first outbreak of H1N1, people actually paid very close attention to infection control procedures in the hospital. So that may not be representative of the general risk of the ER population of getting infectious diseases. Think about influenza. The virus has hemagglutinin protein sticking out of its envelope. There's a head and a stalk to this hemagglutinin. The head varies a lot, the stalk does not. One of the interesting discoveries about the H1N1 pandemic is that the H1N1, unlike other influenzas, leads to the generation of antibody against the stalk of influenza hemagglutinin, which is a conserved protein and does not mutate appreciably. Not only do you get that effect in some people who get the disease from H1N1, it occurs with the vaccine to H1N1, and it also occurred from the New Jersey vaccine from the 1976 swine flu. And that people who get the influenza vaccine who had prior exposure to the New Jersey 1976 strain had a marked boost in their antibodies directed against the stalk of the hemagglutinin. So one of the potential benefits of people either getting infected or vaccinated with H1N1 is that some percentage of the population, and I can't tell from this article what percentage that may be, will have broadly cross-reactive antibodies against the influenza A hemagglutinin stalk and potentially have protection against multiple strains of future influenza A. This is also serving as a hint as to how to come up with a universal flu vaccine, which we really, really need. One of the brouhahas in science this year was whether or not they should have published information showing how to change H5N1, the avian flu, from a bird flu to one that easily infects human beings. Someone did that for hoots and giggles and wanted to publish it. And then people worried that someone would then do that as, say, a bioterrorism project. This study looked at what's happening in nature and finds that H5N1 is undergoing substantial antigenic drift. No big surprise, flu does that. It's a sloppy reproducer, not unlike human beings. But that there are no mutations that suggest it's being altered in a way that increases its pathogenicity or infectiousness towards human beings. So far, H5N1, avian flu, is not going the way of H1N1, the swine flu, by becoming highly infectious to human beings. An interesting study just on the epidemiology of mononucleosis, i.e. primary EBV infections in university students. This was done out of Minnesota. They looked at a bunch of college students and followed them along, and if they developed mono, they did a bunch of lab tests on them. They found that it was kissing, with or without coitus, that led to spread of the disease. That viremia was associated with severity of symptoms. The higher the viral load, the more sick patients were. But oral shedding lasted a long time, a mean of 175 days. And the other interesting thing about EBV is the majority of patients were symptomatic. Only 11% were asymptomatic. 77% had classic mono, and 12% had atypical symptoms. I remember in high school, mono was always called the kissing disease. Don't know if you could get it from reduvid bugs or not, but it seems that that nickname is appropriate. For those of you who may not be aware of the obscure infectious disease references, reduvid bugs, which spread Chagas disease, are also called kissing bugs, hence the prior reference. Not to imply that you get mono from kissing a bug, but from kissing bugs. You know, if you have to explain a pun or a joke, there's really no sense in even trying, is there? A couple of viral hodgepodge issues. One, a meta-analysis shows that the longer you give nursing women antiretrovirals, the greater the reduction in the risk of infection in the child. That hepatitis E is a cause of chronic hepatitis in transplant patients, and those that have that have some abnormal regulation of their interferon genes. And finally, as part of HIV and hepatitis C with cirrhosis, that there's an increase in hepatocellular carcinoma in HIV-infected patients in Spain, but I don't know why it couldn't be elsewhere as well. And that's your viral hodgepodge. Let's go on to more advanced organisms. The same tick that can spread Lyme can also spread human granulocytic anaplasmosis, or HGA. The question is how common. There are some labs, of course, that diagnose Lyme and anaplasmosis in everybody. Don't get me started. But in the real world, where you actually use reasonable diagnostic testing, in this study, which used isolation of human anaplasma from the blood as the gold standard, found that there was a co-infection somewhere around 2 to 10%, depending on whether or not you used just isolation, serology, or isolation of the organism plus serology. I think 10% would be a good working number. Those who had human anaplasmosis were also more likely to be febrile with their primary Lyme and to have cytopenias with their primary Lyme. So you can put the Lyme with the anaplasma. Then you can call the doc and woke him up and ask, "Doctor, is there nothing I can take?" I said, "Doctor, to relieve this limey ache." I'm not on a roll today. It's New Year's. I'm tired. When I think of listeria, I think unpasteurized milk as the predominant source. However, when you look at the recent emerging infectious disease analysis of 24 listeriosis outbreaks by food category, you find deli meats are number one. Frankfurters, which is the worst way to get it, is number two, followed by Mexican-style cheeses, salads, and other meats. So there are a wide variety of potential food vehicles by which one can get listeriosis. And clinical infectious diseases has an outbreak that caused a baffling, lengthy outbreak of hospital-acquired listeria that was finally traced back to contaminated diced celery. Again, the importance of deep frying everything you eat. It's even worse than I thought. I had no idea that there were bacteria whose growth are dependent upon the presence of antibiotics. In the references to the particular paper I'm going to talk about, they talk about a vancomycin-dependent Enterococcus, a vancomycin-dependent Staph aureus, and a streptomycin-dependent Mycobacterium tuberculosis. And now they're describing coag-negative staph that are dependent upon the presence of linezolid to grow. This study defines 5 strains of Staph epidermidis that were isolated in the blood that, quote, grew substantially faster at 32 micrograms per mil of linezolid. What the hell? Now we're feeding the bugs with antibiotics? This is depressing. I had no idea. But it's certainly yet another mechanism by which the use of antibiotics will perpetuate resistance in your environment. Who gets abscesses with cellulitis? It doesn't happen very often. In this series, abscesses occurred in only 8%. And they found that the medical issues related to abscess formation were male gender, smoking, alcohol abuse, and delayed antibiotics. Then they used the magic that is multivariate analysis, like I understand statistics. I took and dropped statistics 4 times in college, once a year for 4 years. They found that chronic alcohol use and delayed antibiotic treatment were independently associated with abscess formation. So worry about abscesses in your drinking delayed antibiotic cellulitis. Abscess makes the heart grow fonder. I don't quibble too much about initial antibiotics in patients. You got to kill what might kill your patient. It's what you do after the dust settles where I may be snide and sarcastic. One of my general rules of thumb is that if you don't grow MRSA out of a body fluid, it ain't there. But pneumonias can be problematic, and we rarely get good sputum specimens for community-acquired pneumonia. So let's say you start a patient on healthcare-associated pneumonia guideline therapy. Is it safe to stop the vancomycin when, as usual, you have crappy or non-existent cultures? And the answer is yes. In this study, they did a retrospective review and found that if A, they had a negative nasal and throat cultures, and B, their clinical pulmonary infection score is less than 6, then you could safely discontinue the vancomycin and not have to worry about MRSA pneumonia. I hate saying MRSA. I like saying MRSA. I have mentioned in the past that the combination of daptomycin and beta-lactams increases the efficacy of daptomycin. Nafcillin, even in MRSA patients, makes daptomycin more efficacious. This retrospective study looked at the clinical results of this and found that daptomycin had increased efficacy when combined with a beta-lactam, especially in people with endocarditis, bone and joint infections, and bacteremia of an unknown source. 90% success versus 57% in those that didn't get a simultaneous beta-lactam. There have been in vitro studies to demonstrate the increased effect of daptomycin secondary to the addition of nafcillin. So there is biologic plausibility for this. And there's also issues with the rapid development of daptomycin resistance in patients who either have long-term staph infections where they mutate in response to platelet factors or in response to the antibiotic themselves. So I'm going to stick that in my back pocket as something to think about for a while. Not certain I recommend it, but sometimes your back's against the wall with these staph infections, and that might be the thing to do. One of the things that boggles my mind is the fact that people frequently treat infections when they don't know what the hell they're doing. I mean, nobody would treat, say, cancer without calling an oncologist. And most people would not deliver a baby without calling OB or FP to give them a hand. However, people treat infections all the time without knowing what the hell they're doing and screwing up. They especially do it with staph bacteremia. Just a couple weeks ago, I had a patient who was sent home on oral clindamycin who had a primary staphylococcal bacteremia. Ugh. As I tell the house staff on service, when they're old and demented in the ICU, they can't remember their name and they're incontinent, the one piece of information I want them to say as their last words as they go into the great beyond is that the minimum duration of treatment of Staph aureus bacteremia is 14 days. Of intravenous antibiotics, damn it, and not clindamycin. Jesus. So this study went back and looked at patients with staph bacteremia and whether they had a short course, 14 days, or an intermediate course, greater than 14 days, for staph bacteremia of a variety of sources. And they found that primary bacteremia, which is always considered endocarditis, had a high relapse rate if patients got less than 14 days. So that they suggested that everyone should indeed get the 14 days of IV therapy for their staph bacteremia unless it was staph bacteremia without a focus, i.e., IE, in which case they should get a longer course even if there is no good documentation of a complicated infection. I will mention here as well, there are now at least, I think, about half a dozen studies to show that staph bacteremia plus ID consult equals improved outcomes by all measures. Because, you may not believe this, but infectious disease doctors really do know more than you about the treatment of infections. It's all the Dunning-Kruger phenomenon, where the person least likely to know about a topic is the most confident that they have mastered the topic and are the least likely to recognize that they don't know a burrow from a burrow, i.e. an ass from a hole in the ground. There's an ongoing balance when you do podcasting or blogging between whether or not you think your listeners/readers have heard what you said before, or that this is the first time that they've accessed my particular genius and I need to repeat background information. So if you hear things more than once because you're a long-time listener, I usually try and do these with the assumption that anybody who's listening is listening for the first time. Now, as you probably know, though, that heroin is not sterile. It is a rich microbiologic milieu of a wide variety of organisms. I never say that heroin is contaminated because that makes it sound like they're trying to make it sterile. They're not. There's been a problem in the United Kingdom, which I believe was just bought by Disneyland to make the United Magic Kingdom. That's an Onion joke. Thank you very much, Onion. But they went and looked at the number of infections with spore-forming bacteria. What are spore-forming bacteria? Primarily the Clostridial species and anthrax. And they found that in England and in Scotland, there was an ongoing problem but intermittent problem with infections due to Clostridium novyi, Novyi, and anthrax, which I've talked about before, whereas the rates of tetanus and botulism are holding steady. The rates were quite remarkable in heroin users, with 1.45 per thousand in England and 4 per thousand in Scotland. That's among persons who inject drugs, or PWIDs. So if you're going to be a heroin user this year, and what better way to spend 2013 than addicted to heroin, please remember that any number of spore-forming organisms can be found in your heroin, and you may come down with something fun like tetanus or botulism or even anthrax. It's just not a healthy lifestyle. In England, there is a problem with Mycobacterium bovis in cows. And it is perpetuated by a reservoir due to the Eurasian badger, and that the Eurasian badger is a focus for recurrent infections in herds. The study looked at the effect of badger culling to prevent bovine tuberculosis in Great Britain, and it didn't do much, unfortunately. So the interactions between the badgers and the cows are more complicated than just killing off a bunch of badgers to protect your cows. I guess that's why you don't have to show me no stinking badgers. That's a long way to go for a Treasure of the Sierra Madre pun. What the hell? I just thought it was very interesting that badgers and cows are a environmental pair in England that perpetuates the illness in cattle. So a meta-analysis suggests that 150 milligrams of fluconazole given once a week is good for prophylaxis against recurrent vulvovaginal candidiasis. However, they found 249 articles and they only included 2 in the meta-analysis. 2 does not a meta-analysis make. This is almost as amusing as the meta-analysis by the Cochrane folks on the use of acupuncture for mumps, where they did a meta-analysis on 1 article. It's like when we watch basketball. My boys, especially my youngest, is obsessed with the NBA, and he always talks about a team being on a winning streak or a losing streak. But how many games does it take before you're on a streak? I think it's 3. 2 does not a streak make. 2 does not a meta-analysis make. Speaking of meta-analyses, how do you treat toenail fungus? Terbinafine or itraconazole? This meta-analysis suggests that itraconazole is more likely to lead to recurrence than terbinafine. I'm biased by the fact I've seen somebody die of terbinafine liver hepatitis, and I'm a little leery about killing people just to make their toenails look better. But for some people, looking good is more important than being alive. But you'd be surprised how many people don't take terbinafine if you mention in passing, oh yeah, I once saw a patient die after taking this. I know. In my experience, the most dangerous words in medicine. I had not prescribed the terbinafine. The patient came in liver failure and died as a result of the medication. But you always remember those bad outcomes, and they tend to have an inordinate influence on the way you approach medicine. At least they do for me. My successes don't mean anywhere near as much as the failures and complications. I think that's probably the opposite of the standard CAM provider. And there was an interesting study that looked at the use of probiotics around the time of bowel surgery in patients with colorectal cancer. They randomized patients to either placebo or probiotics that started 6 days before the surgery and continued to 10 days after the surgery. And they found a decrease in infections in the group who got probiotics, including septicemia. And you think, oh, that's nice. I wonder how that works. Is it due to modulation of the gut flora? Is it due to the fact that if you give someone a bunch of foreign bacteria that you were sort of prime their immune system? And then you say, wow, in the probiotic group, there were 41 episodes of septicemia. And in the placebo group, there were 55 episodes of septicemia. In the placebo group, there were 12 line infections versus 4 in the group that received probiotics. And then you have to start to wonder, how the hell are they treating these patients to get these remarkably awful infection rates in their post-op patients? It looks like the studies were done in China, and my take-home is they have a lot of work to do on infection prevention in their patient populations. They are sloppy as all hell if those are their baseline septicemia and catheter infection rates. But still, it's an intriguing idea to give people probiotics perioperatively, not only to decrease the risk of antibiotic-associated diarrhea, but to perhaps, I hate to say this, it just gives me the willies, boost their immune system so that they're more able in a proactive way to deal with sloppy surgery technique. Jeez. I don't know. Am I starting the year off a bit more ranty than usual? Maybe not. For those of you who live for guidelines, the Infectious Disease Society of America released their guidelines for the treatment of prosthetic joint infections. And if you are out of Ambien, I can highly recommend it. All the guidelines are incredibly valuable, but incredibly boring to read. They also have released in clinical infectious diseases, infection prevention and control during prolonged human space travel. For those of you who are planning to go to Mars in the next couple of years, I can strongly recommend you read the article. And finally, some of you, I'm sure, will be going to prison in the years to come. When you do, might I suggest you avoid Pruno. What, you ask, is Pruno? Well, Pruno is not home brewed, it's prison brewed alcoholic beverages. They steal scraps from the kitchen, put it in the toilet, for example, and ferment it. The ketchup is one of the prime ingredients, as are potato skins. And potato skins have long been known to carry Clostridium botulinum spores. And there was an outbreak in Utah of botulism in a prison from a Pruno that they think was probably due to potato skins. The CDC site suggests that Pruno has both the consistency, smell, and taste of, is it vomit or stool? I forget. But I'm going to stick with IPAs and Bordeaux's. And that's it. I try reasonably hard to keep this at 30 minutes. I think 30 minutes twice a month is the most that anyone can tolerate listening to me talk. So that ends the Puscast, covering the last 2 weeks of 2012 and the first podcast of 2013. Happy New Year. The references are available online. You can find my growing multimedia empire at edgydoc.com, where you will find links to my blogs, my podcasts, my books, my iPhone apps. Otherwise, I would like to thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. Thank you. In dictation, go Ducks.